It's a pleasure to introduce a longtime friend and colleague, Pete Sanderson. Pete is now the Chief Executive Officer, I get that right, Pete, of Ascension?
Actually, I'm the VP of Care Transformation for Ascension, Wisconsin.
Okay, VP of Care Transformation for Ascension, Wisconsin.
Correct.
But he has walked the walk. He started his practice in the days when he developed his own x-rays in a two-person clinic, and it was up near, was it Plover?
It was in Plover, Wisconsin,
Plover,
right?
Wisconsin. So he has walked the walk, and now we'll hear from him about care transformation,
Thank you.
the view from the C-suite.
So, yeah, as John mentioned, the two of us go way back. I was part of the first group of family practice residents to go through the residency program in Appleton, and John was one of my mentors then. Now, I considered him an old man at the time, so I don't know what that makes of both of us. So we're going to talk a little bit about the joy of medicine from the C-suite, and I'll present some results of our Joy of Medicine project, and I'll talk a little bit about what that is. But the major thing that I want to help you to understand is some of the events that have to occur once you come to a conclusion that some initiative makes some sense before you can begin to get it into full-blown implementation. And I'm from Ascension Medical Group, Wisconsin. Ascension Medical Group is the largest medical group that you've never heard of. We have 1,600 clinicians in Wisconsin, and the reason that you've never heard of us is at the moment we go by our legacy names, the Wheaton Franciscans in the south of Milwaukee, Columbia St. Mary's, Ministry Healthcare, and Affinity. And my main location is in Stevens Point. Over the course of time, I've had operational responsibilities for our clinicians in central Wisconsin, our clinicians in northern Wisconsin, and I've had a fair number of statewide initiatives that I've been responsible for. I think over the course of the years, virtually every C denotion you can have, CEO, CMO, Chief Medical Information Officer, I've filled those roles over the course of time. As a practicing clinician, I've always felt that my job is to serve the needs of patients. As an administrative physician, and I go back and forth from being an administrative physician to a practicing physician, my job is to serve the needs of those that serve patients. And my career has been spent in trying to serve the needs of caregivers and clinicians. We're also part of a larger organization that's called Ascension Healthcare, and all the states that have dots in it are where Ascension has a presence. Ascension is the largest nonprofit healthcare company in the country. So if you think of any healthcare company, Ascension will be bigger. And folks will say Mayo, much bigger than Mayo. Cleveland Clinic, much bigger than Cleveland Clinic. Kaiser Permanente, yeah, we're even bigger than Kaiser Permanente. But again, we're the largest healthcare company that you've never heard of because each entity is still known by their legacy names. And some of the issues that we'll talk about later are issues that have to do with our bigness, but that also gives us tremendous opportunity because once we're able to show the value of a particular project or approach, we do have the ability of spreading it over the country relatively quickly. So we responded to the State Medical Society survey, the Wisconsin Medical Society survey back in 2014 that said 82% of respondents to the survey, these were physicians, responded that they had at least one symptom of burnout. And that was a big eye-opener for us because we had seen that level of burnout was increasing over the course of time. I'll mention that many people point to the electronic health record as a cause of burnout. I think it's just one of the many causes because we were seeing burnout before the electronic health record ever came into being. And the concept that we came under is we said that if so many physicians are suffering from burnout, there must be something fundamentally wrong with how we're practicing medicine. And one of the important things to recognize from the State Medical Society survey is that it didn't make a difference whether the physician was rural or urban. It didn't make a difference whether the physician was self-employed or employed. It didn't make a difference whether they were a faith-based organization or a non-faith-based organization. It didn't make a difference whether they were solo practitioners or they were part of the biggest system within the state. Every single setting showed significant burnout. Now, for those of you that are in industrial engineering, that should say you've got a wonderful opportunity because healthcare is ripe for fixing. It is horribly broken. It's broken on a national basis. It's broken how we've chosen to reimburse it, and it's broken at the practice level. And we have an opportunity to make a difference. As an organization, we have always believed in the quadruple aim. Many people know about the triple aim. Triple aim meaning we want to see better outcomes, we want to see lower costs, and we want to see an improved patient experience. But increasingly, organizations are also saying we have to be concerned about the caregiver experience. In this particular slide, it says improved physician experience, but it really is caregiver experience. And recently, the Wisconsin Medical Society endorsed the concept that as a society, we need to be pushing for the quadruple aim. And that if you don't have physicians who are happy and satisfied, you're not going to have a good healthcare system. Now, I would ask each of you to sit back and think, when you're in pain and you're suffering, how good a decision do you make? It isn't as good as it could be. And if 80-some% of our clinicians are suffering from some symptom of burnout, what does that mean in terms of the quality of decision making that our caregivers are giving? Now, I'll give you a number of what I call Sanderson-isms, and they're little sayings that I use all the time to be making a point. But if you believe in the quadruple aim, then you have to be willing to put ruples in the quadruple aim. Now, I coined that before our current political climate, but the idea is that we put money into getting better outcomes, we put money into lowering costs, and we put money into improved patient experience. We need to be putting money into improving our caregiver experience. So if you believe in the quadruple aim, you got to put ruples in the quadruple. Following a study that Sinsky, who will be presenting here tomorrow, did, looking at a variety of primary care practices that showed increased clinician experience, we put together a team to revision how we would go about providing care. Now, I'm happy to say that that team was led by a person that you might say is an industrial engineer. So for a long time, we've embedded Lean and Six Sigma experts into our medical group, into our regions. And most of our industrial engineers come from industry. Generally, I don't like to hire Lean Six Sigma folks from healthcare because their minds are polluted with our current way of doing things. And if we're so totally broken, I want to hear from an industrial expert about how to do the job right. So this effort was led by one of our Lean Six Sigma engineers and redesigned and revisioned how we provide care. In essence, what it did is it said we need to add patient care staff to the care team so that we do team-based care. So in essence, the patient care staff involves one patient care staff that all they do is that they handle the doctor not here, or the patient not here work. The medication refills, looking at prepping a chart for tomorrow, the phone calls that are coming in. And then we have two patient care staff that are dedicated to caring for the patient. And where the change in the model is that a patient care staff, one person is responsible for one patient at a time. They go out to the reception area, pull the patient into the, get their vitals, pull them into the exam room and do their medication reconciliation and begin the documentation process. That patient care staff person stays with the patient for the rest of the visit. They wait in the room with the patient while the caregiver is doing work someplace else, and then the caregiver comes into the room, and the nurse, the care specialist, presents the patient to the clinician. So it's a handoff. It's a team-based care. And the patient has an opportunity to correct any of the information that is being given during the handoff. And then that person quietly sits in the background and becomes a scribe. And when it's time for the clinician to say, here are some additional things that we're going to be doing. If it's lab work, that patient care staff actually draws the blood work in the exam room. If it's an EKG, they do the EKG. If another study needs to be scheduled, they schedule it right in the exam room. If a medication is prescribed, they type in the medication, and all the clinician really has to do is be able to say, yep, that's what I'm doing. So the intent is to have a single piece flow for the patient and have a system set up so that when the care staff leaves at the end of the day, the physician leaves with them. So there's no after hours work, there's no work after work. And if you think about it, these are all the concepts that clinicians are looking for. I want more eyeball contact with my patients. I want less of a relationship with paper. I want less of a relationship with the computer. And that's the intent. Now, the feedback from our clinicians that have participated in this project have been fabulous. I've really only heard one negative comment, two negative comments. The first is, I used to get home after my wife got home from work and she had dinner on the table. Now I get home before my wife gets home from work and she expects me to have dinner on the table. So that's been one negative comment. The other thing that we learned is that if you do this with just one clinician at a site, you haven't trained enough patient care staff to assist that clinician, because inevitably someone leaves, someone goes on maternity leave, someone has FMLA of some kind, and now the clinician is really put in arrears because they don't have the support people that they need. So what were some of the results that we saw? Well, provider productivity improved by 22%, provider satisfaction by an average of 42%. We did a Joy of Medicine index, which was our own survey that we had providers take before and at the 90-day period, and their satisfaction just skyrocketed. Staff satisfaction, staff took the same survey and their satisfaction went up by 39%. Our ACO quality performance metrics improved by an average of 3%. Now that may not sound like a lot, but our quality metrics, our ACO quality metrics, so those are things such as the percent of smokers that you addressed their smoking history with them, the percent of patients that have a low hemoglobin A1C, the number of patients that you've checked their cholesterol or their blood pressure is under control. May not seem like a lot, the 3% decrease, but this is in a practice setting where our medical group in Wisconsin leads all of Ascension in terms of our quality metrics. And in the particular region in Wisconsin that we first did this region led the state. So already extremely high levels of quality, still improved by 3%. And it had a positive ROI. Now, positive ROI means return on investment. Now, in essence, what that means is that the costs that we spent in order to do the Joy of Medicine were recouped with the additional revenues. Now, you would think with this type of stellar results that would be enough for everybody to say, we're going to bless this, You're going to do it throughout the entire organization, and everybody is going to be happy. Not so fast. And for those of you that are in a research mode, industrial engineering, for those of you that are early in your training, you may oftentimes say, we've done this great study, and why is it that not everybody is taking it up and making great changes? Well, there's lots of organizational issues that you have to overcome. So before I get into those issues, any questions you have about the Joy of Medicine project as we visioned it, or the presentation so far? Yes, sir, in the back. So the question was, how many pilot sites did we run? Initially, we ran one pilot site with 2 clinicians. And this was the 90-day results for those 2 clinicians. Other questions? Yes, sir.
Did you choose the pilots based on any kind of animal risk assessment or weighted risk?
We strategically, or did we choose the pilot sites based on any criteria? Yes, we chose it based on the willingness of the provider to be involved, because this is a major change in how a clinician practices. So I think of this and say that as clinicians, we have songs that we play in our mind all the time. We have a review of system song. We have a history of present illness song. We have an opera that plays off in our mind about how an office visit goes. This changes the dynamics of the office visit, and it takes retraining of the staff, it takes retraining of the clinician, and it takes about 90 days to learn the new dance. So you've got to have very motivated clinicians. Very perceptive question. So we picked clinicians that we knew we would be successful with. Back here.
What was the background of the kids that cared by the non-clinicians?
The background of the non-clinicians. So this was in an internal medicine site in a major clinic setting in Stevens Point, Wisconsin. Very motivated patients, very motivated clinicians, and we went with a 2RN model. So the patient care staff that we added to be with the patient, we chose RNs because we wanted to have the training that an RN had in order to address a number of the social issues. In fact, what we found are several instances where patients had said, I've been refusing colonoscopy, and because we had an RN model, the RN said, well, let's talk about this a bit more. And we found out that they had arthritis, and they didn't want to be off their anti-inflammatory agents prior in order for the colonoscopy. And it took the skills of a RN to be able to say, well, we have alternatives to that. So that's a very perceptive question as well, and is one of the reasons that we ran into some issues. So what were the concerns that were listed by a number of the people that were in C-suite level within operations? One, you used only the most motivated clinicians in the site, and how do we know we'd be getting the same kind of results? So, great question. Two, the pilot was at a patient-centered medical home. This is already a highly functioning care system, and how do we know that it'll work in other systems? The pilot was in internal medicine. How do you know it's going to work in family practice? And there was a lot of skepticism about the ROI. And that ended up being one of the biggest issues that we had to resolve. Even though we used a regional chief financial officer to help us put together the ROI, everybody and his brother poked fun at our ROI. And that was a major thing we had to overcome. It put us to have our staffing over benchmarks. And being part of a national organization, especially part of a national organization where we're reorganizing Wisconsin. I mentioned to you that we have 4 different legacy healthcare systems. Over the past 18 months, we've been collapsing that into one. And as part of that collapsing, people pay a lot of attention to what the benchmarks are for staffing. And adding staff for Joy of Medicine put us over the benchmarks. And one of the things that I kept saying is that if you want to be the best, you have to do it like nobody else. And if all that you're doing is you're looking at the benchmarks, all you can be is mediocre. And we just kept hammering that over and over again. We used a 2 RN staffing model. Why not an RN or an MA? Why not a 2 MA model? Doctors will use this model just to get home earlier rather than see more patients. My feeling with that, if they're happier and they get home earlier, I'm happy with that. But that was not the attitude of our chief financial officers and other people that weren't quite so close to the care teams. We also ran into problems with coding and compliance. So those of you that have some experience in coding and compliance will recognize that Medicare says that only the caregiver can document the history of present illness. So you can't have a scribe documenting the history of present illness for the caregiver. So we had to work our way around that. And then we found that having a scribe in the room actually increased the amount of information that was documented, and our level of coding began to go up. And then we began to have discussions about whether that level of documentation and coding was supported by what typically would be the level of service that would be charged for that type of a visit. So you could have somebody that came in with strep throat that you ended up having a very complex visit because you touched on lots of other issues as it related to strep throat, which is actually great care, but the coding and compliance people had issues with that. And the last issue we had is with human resources. And this is something you really need to be thinking about with any of your little special projects that you go on, because what began to happen is that these RNs, MAs, LPNs, whatever we had for extra care staff, people began to say, but they have more training than somebody else, and shouldn't they be paid differently? So that's pay equity. In essence, what happened is we looked at what the job titles were, and they're working within the scope of their license, hence they fit within the same pay equity, and there was no difference in the pay between someone that participated in the project and those that didn't. But we also ran into troubles with other care team members, including physicians in an office that had a pilot. Well, just wait a minute. They can see more patients because they've got extra staff. Just give me extra staff and I'll be able to get out on time too. So there were lots of issues that occurred. And the last issue that I didn't put up here is that you got to have enough care staff trained so that you can cover for maternity leave, FMLA, vacations. Because if a physician becomes dependent on the Joy of Medicine to see their patients and they don't have that support any longer, they just get totally devastated. So we expanded the pilot to 17 sites. So when I say 17 sites, I really mean 17 clinicians, because we typically always made sure we had at least 2 clinicians at a site. So we had them at rural and urban, internal medicine, family practice, patient-centered medical home, non-patient-centered medical home. We used MA models, we used RN-MA models, and we continued with the RN-RN models. Additional challenges, we were consolidating as a healthcare organization. And where we used to have 4 chief financial officers for the medical group, we consolidated down to 1. That meant that the leadership structure was constantly changing, and we constantly needed to reinforce what the Joy of Medicine was. And we were always having to say, this is what it means, this is not what it means, and that was a huge challenge for us. As part of that, we had leadership changes. And during consolidation, you have a change in who your leadership is within the medical group. Now, this was both a plus and a minus. My regional vice president in Stevens Point, that was the champion of this project, became the president of the medical group. And it gave us an opportunity to talk about the concept that as a leader, everything that good that happens with the organization occurs because of the hard work and dedication of our associates. Anything that bad that happens within the organization is somehow due to our inability to effectively lead, manage, set up policies and procedures. So what occurred is that one of our medical directors, who had been in the pilot project, became a regional vice president. And she then was able to take the work that had been done in the data and begin to present it to senior leadership as where we need to go with Joy of Medicine. And our president had to say a couple of times, she's getting all the credit. And I'm going, yeah, isn't that great? Because now she takes up the mantle for you. So this is part of leadership development as well. And we found that the clinicians that generally participated in the pilot were also some of our better leaders, and they became great leaders in our new organization. So it was part of leadership development for us as well. We also had several reductions in workforce. And I'd ask you to stop and consider how likely it is to be able to add FTEs when you're going through a cycle of reduction in workforce. In fact, I was told on several occasions, forget it. In this environment, you'll never get more FTEs. Well, that's just the challenge that I need to say, okay, we got to figure out how to do this. Non-clinicians do not understand the workflow because they've never been in an exam room. They don't know how clinicians interact with patients. Clinicians, by and large, looked at this and intuitively said, yes, as long as they could get to the point of saying, I'm able to rely on my care staff to do some of the essential functions within the office, they looked at this and said, this is a great idea. And lastly, as I already mentioned, is department equity. And we found some departments that were part of the pilot were quite happy, and those that weren't happy. That's actually a good thing, because when we finally get Joy of Medicine to them, now they're willing participants as opposed to participants that we have to force them. So what did we find when we did the expanded pilot? We saw that provider productivity improved in every instance, but it was inconsistent. We saw provider satisfaction improve significantly. We saw improved ACO metrics every place that we did the project, but not as much as in the initial internal medicine. Partially because the two internists that we chose were anal retentive about their quality metrics. They huddled with their care team at the beginning of the day and identified patients that still had gaps in care. In our system, the electronic health record tracks the gaps in care, those that haven't had a flu shot, those that haven't had a mammogram, and we call those gaps in care. They huddled at the beginning of the day and identified patients that they had to put special activity on in order to close the gaps of care. And then they huddled at the end of the day and figured out where they were not successful and what they could do differently next time. That is unusual behavior in a medical office. We found no advantage to the RN staffing model. Surprise to me. I figured that the RN staffing model would be far better than the RN MA or the MA MA. I think it's because the majority of clinicians did not know effectively how to use an RN. If you empower the RN to have some of those crucial discussions, like the internal medicine team in the original pilot, I think it can make a difference. But we did not see that across the board. It allowed us to significantly source new leadership and have new leadership development, and that should not be overlooked. Any major change that you're trying to get through your system, if you can identify new leaders because of it, because they're willing to step to the plate and move forward, that's a positive for your organization. And it forced us to have a discussion about the total value of a primary care visit. And that became the essence of what ROI was. Is the ROI just based on the professional charges of the clinician, or is the ROI also including all of the downstream revenues that occur with the patient? Also, another Sandersonism came into this because we kept hearing, well, we don't want to add to the subsidy we make to the physicians within our organization. And in our organization, all of our ancillary services are billed through the hospital. So that means if I order a CT or MRI or a CBC or a urine, the hospital gets credit for it, not me. And I kept saying, if you cost account the ancillary based on where it was ordered, we'll have a subsidy per hospital bed, not a subsidy per physician. You can imagine in a large integrated healthcare system, that was not a very popular comment, but was one that forced the discussion to go forward. So as I mentioned, the ROI was the most difficult thing for us to overcome. In essence, our chief financial officers kept saying, show me the money. And with that, it helped to reconfirm that one of the most important things that leaders do is stakeholder analysis and stakeholder engagement. And when you think about it, when you have an initiative that fails, typically it's because you didn't do a good enough job of identifying who your stakeholders are and what they need in order to make a decision that's in your favor. In this case, our CFOs were negative, and we needed to at least have them neutral, but I actually wanted to have them positive. So how do you get a CFO to be positive about an ROI? You give them skin in the game. So what we did is we said, okay, CFOs, you tell us how to do a ROI, and you tell us how many new patients we have to have in a day in order to cost justify that. That way, we were arguing with them about their ROI. They weren't arguing with us. That way, when the budget got put together, they could justify it, and they could go to senior leadership at the state level and at the national level and be able to plead our case. And that was the single best thing that we did. So we changed a stakeholder that from where we were sponsors defending the ROI to the CFOs establishing the parameters and becoming the champions of ROI. So we decided to have a provider attribution. You don't get to be part of the joy of medicine just because you want to. First of all, you have to have at least median productivity for your specialty. Second of all, we have to have demand available to support the increased volume. So we had to do capacity and demand analysis. Third, you have to be a provider that has positive performance, meaning we don't have medical record issues with you, you're not on a performance improvement plan, you are a good citizen. And lastly, you have to have interest in agreement to follow the standard model. And that's the key that we needed in order to move this forward. So what do I mean by that? We have clinicians sign an accountability agreement. They agree that they're going to adopt the joy of medicine concept. They agree that they're going to attend training sessions. They agree they're going to huddle daily. If you've ever tried to get clinicians in a huddle at the beginning of the day, it's nearly impossible. They agree that they're going to work with their clinical staff to achieve maximum results, that they're going to be on time for work, and they're going to work on continuous improvement of quality metrics to achieve the goals. Now you might say, well, what's the teeth in this? The teeth is you either agree to do this or you don't get additional staff to do the joy of medicine. And if you don't keep doing it, we're going to take that staff away. So that's the teeth. And then a real key piece is that the CFOs helped us to establish for each clinician that was proposed to be part of the Joy of Medicine project, what is their expected RVU increase and what is their expected visit increase over the next 6 months. And then we ask the providers to sign it. Now, this then provides the contract with the provider that says you'll achieve these or we'll remove the resources. that provides the CFO accountability that we're either going to meet the metrics or we're taking it back. But the other thing it does is it allows us to extend this to advanced practice clinicians, PAs and Ps, and allows us to establish it with specialists. It just takes the calculations to be able to figure out what do they need. Now, I haven't provided you with what those calculations are because it's actually different for every clinician, and it's based on how many RVUs they see per visit, what their net marginal revenue is, and what other factors the CFOs have decided to put in and not put in. The key piece for you is that if you run into these issues, you got to go to the stakeholder that can derail you and have them become champions and have them establish what they consider to be the parameters. Could be that your parameters are different than our parameters. The important thing is that you come to agreement what those parameters are and you put in accountability. Now, we didn't stop with just the physicians. We also went with the associates that we hired to be part of this care model. And they basically sign a very similar agreement. And we also went with the practice managers because this requires the collection of data. This requires the acceptance of additional training. This requires a lot of work on the manager part. And if they want to be part of the project and they want a clinician to be part of the project, we have them sign on the dotted line as well. Now, where are we? Well, we've gotten the agreement to expand this to 40 clinicians throughout the state. We could probably do more, but this takes additional training, and we just don't have the resources to train more than 40. And I would look at this as being a stepwise approach that will go from 17 to 57, and any of the 17 that don't keep up their metrics, they'll be cut out of the system. And if we stay true to our word and we include only clinicians that stay current with the agreement, I think we'll get the agreement to go to more clinicians. Now, an important piece of this is because we're part of Ascension National, Wisconsin is Ascension's single most important market. We're their biggest market. They're using us as their reference market, meaning what works here, they want to try putting it elsewhere. I'm beginning to get phone calls from Texas and New York and Michigan and Indiana saying, what are you guys doing and how did you work through these issues? So what's beginning to happen is a snowballing effect whereby we've established a way of doing things here, and it's in the process of being propagated across the country. So that's the State of Our Joy of Medicine project. The key thing I would encourage you to do as you try to implement it is establish who are all the different stakeholders and what issues are they likely to have, and you need to work through those issues. And recognize that from the time that the study says it's a good thing to do to the time that you actually begin to put it into place takes an awful lot of work and an awful lot of commitment from a large number of people. But it can happen if you keep working your way through it and you satisfy the requirements of the various stakeholders.